कर दे. What do you say, Sai?
Yes, doctor.
You're still adding people?
People are coming in, but we can start, doctor.
Okay.
Stop sharing.
Once you stop sharing, should I? Otherwise, it's okay if he keeps the presentation. I'll start.
My share.
नहीं कर सकता ठीक है नहीं तो it's okay.
It is not shared.
नहीं, it is still seeing.
Okay, fine. Stop share is there. Yeah. Okay.
Yeah. Now you can focus the spotlight on me. So we start. Very good evening to all the dear MOS members and the ophthalmic participants who are there pan India. We are in the 6th quiz league today. That is the month of June. I hope everybody has joined on 2 devices. Participants have to go to the second device on the Slido platform. There is a lot of noise somewhere. On the Slido platform, so you can see your marks and play on that. We have 2 quiz masters with us, star quiz master Dr. Medha Prabhudesai and Dr. Nitin Prabhudesai, husband and wife duo, who are already holding quiz on the POS platform for years together. And this is their chance on the MOS platform. So now, all the best, happy quizzing to all the participants, and all the best. I hand over this thing to Dr. Medha and Dr. Nitin for further proceedings. Over to you, Nitin and Medha. You can start sharing it. The rules are, those who are already have won this thing in the earlier quiz, previous quiz, are not eligible for prizes. The rest of them, of course, you can compete. And those who have won maximum times, of course, will be given chance in the finals. That is in the Moscow and Nasik we have, which are going to be held in full physical form on 14th, 15th, and 16th of October. So that is the main thing. The rest of the rules, Dr. Nitin is going to explain. Yeah, Nitin.
Okay, shall we start then?
Yes, please.
Good evening, everybody. It's my pleasure to be the part of this MOS quiz here, which has been organized by Dr. Jignesh Taswala, President MOS. And Dr. Taswala has been on the forefront of carrying academic activities in the last whole year. So let's start and have a good quiz time. Okay, the first question is on history of ophthalmology. Moorfields Eye Hospital, one of the premier institutes in the world, known as the First Eye Hospital. Which year was it established? These are your 4 options: 1804, 1805, 1806, or 1807.
You have 20 seconds to answer. Nine more seconds to go. Very simple answer. The easiest of the lot. And the time is over.
Fine.
And the answer is, don't answer on this, please. It's a Slido platform. There is a link which has been sent on the chat box. Please try and go into the second device. The Slido platform will open. That is where you are supposed to answer.
Okay, so you know that this hospital has been there since 1805. So it's almost 200 years old. Now the next question is interesting one. Shall we go ahead, Jignesh?
Yeah.
When was the first eye hospital in India started? We saw the first eye hospital in the world. So when was the first eye hospital in India started? You can see that it was not far behind. The choices are 1817, 1818, 1819, or 1820. Your time starts now. I think those who are vigilant enough would have noticed that the bicentenary aviation had recently occurred, and Dr. Natarajan had taken a big part in that.
We have 4 seconds to go. Quickly answer. We have 50 participants, 37 on Slido. And your time is up. And the answer is 1819.
It was started as Madras Eye Infirmary in Royapet, Chennai, and was renamed as a Regional Ophthalmic Institute and the Government Ophthalmic Hospital in 1888. Recently, we have celebrated its bicentenary event. For your kind information, this hospital is still working. It's still an active hospital. So now some of the clinical questions and the anterior segment. Where is the maximal concentration of conjunctival stem cells? Is it superior and inferior fornix, bulbar conjunctiva, palpebral conjunctiva, or the marginal conjunctiva? Your time starts now.
14 seconds remaining. Very easy answer. A lot of anatomy has to be known and your time is up.
Okay, so the maximum concentration of the conjunctival stem cells in the superior and the inferior fornix.
26% have given the right answer, 53% had seen as a bulbar conjunctiva. Anyway, best luck. Next question coming up.
Which of the following fluorescein pattern is suggestive of neurotrophic keratitis? Again, a day-to-day question. A, B, C, or D. There are different patterns seen here. Neurotrophic keratitis.
Twelve seconds remaining.
I think all of you should get them right.
Last 2 seconds. And your answer is?
Answer is D, the central and inferior cornea.
Absolutely right. 79% people have given the right answer.
That's a good way.
Yes. Next question.
All the following structures are derived from the surface ectoderm except crystalline lens, substantia propria, conjunctival and corneal epithelium, and lacrimal gland. Which one is not derived from the surface ectoderm? Time starts now.
Eight seconds remaining. Again, anatomy for you. And your time is up.
Okay, hope everyone has got it right. Yes,
The
it's the
answer is
substantia propria, which is the only structure not derived from the surface ectoderm.
60%
Most of them have got it
right
right.
answer.
Atopic keratoconjunctivitis, again a common condition, include all except keratoconus, atopic cataract, atopic dermatitis, and interstitial keratitis. Time starts now.
Very interesting questions. 30 seconds remaining. Day-to-day life, you see atopic keratoconjunctivitis also, mainly seasonal. And your time is up. And the answer is?
Interstitial keratitis, because I think there was a lot of clue there. Most
Yes.
of the team had atopic as a name in it itself.
80% have given the right answer. Great going.
Again, an interesting day-to-day question. What is the commonest type of concussion cataract? Is it a rosette cataract, punctate cataract, zonular cataract, or a cortical cataract? Time starts now.
Well, 10 seconds remaining.
Well, let's see
And
the
your time.
answer. It's the punctate cataract, whereas most of them have
88%
given the
have
choice
selected
as rosette
rosette
cataract.
cataract.
Rosette cataract probably we see more with vitrectomy surgeries where we inject gas or oil in the eye. The next question, lens subluxation does not occur in congenital rubella, homocystinuria, congenital syphilis, and Ehlers-Danlos syndrome. Time starts now.
Very nicely depicted picture. 10 seconds to go. You see a lot of subluxations and the causes are very common.
Okay. Okay,
Your time is up.
and the right answer is congenital rubella. This is the only condition where you don't have a subluxated lens. Lens is in position, and along with that, you get even typical fundus picture of salt and pepper fundus. Again, in a day-to-day practice, we see a lot of reaction coming in. So the question is, human lens has which type of antigens? Sequestered antigens, heterophile antigens, cross antigens, isoantigens. Your time starts now.
20
In
seconds
COVID
to
times, you
go.
have been listening about antigens a lot.
12 seconds to go. Great going. Very good questions.
Well, the time is over. The answer is sequestered antigens. The human lens is developed and isolated from the fetal circulation from the 10th week of gestation. Lens antigens are thus sequestered from the immune system, and that's the reason sometimes you may get severe reaction due to the surgery when the antigens are exposed to the body.
76% have given the right answer. Good.
It's a good thing. Again, an interesting question. Which is the only reversible cataract? Congenital cataract, traumatic cataract, galactosemic cataract, or the zonular cataract? Time starts now. A lot of
We
research is
have
going on to restrict the growth of cataract, but this one cataract can be reversed.
time is up.
Time's
Yeah.
up. So I hope everyone has got it right. Yes, almost everyone has got it right. A galactosemic cataract, typically seen as an oil droplet cataract, is an inborn error of metabolism, which is different from diabetes. So we go to the next question now. Infantile nucleus of crystalline lens refers to the nucleus developed from the 3rd month of gestation till birth, birth to 1 year of age, birth to puberty, or 1 year to the age of puberty. Time starts now. While doing cataract surgery, we deal with the nucleus, but this is a little more in depth, which are the various types of nuclear parts.
2 seconds to go and your time is up.
Okay. So the infantile nucleus of the crystalline lens refers to the nucleus which develops from birth to puberty. As you can see in this diagram here, the centralmost is the embryonic one, then we have the fetal, and then we have the infantile followed by adult and then the cortex. Now we shift gears and go to some glaucoma questions. What is the normal aqueous production rate? Is it 2 liters per minute, 2.3 microliters per minute, 2.6 microliters per minute, or 2.9 microliters per minute? Your time starts now. The rate of aqueous production is important because we know how the AC will reform in how much time, especially when the AC goes shallow after glaucoma surgery.
And your time is up.
Okay, so the right answer is 2.3 microliters per minute.
63% have given the right answer. Great.
Good.
We have a knowledgeable participants here. Next question.
Okay, now this is a picture. When you do gonioscopy, you would see this. So the arrow marks the corneal endothelium, scleral spur, Schwalbe's line, or deposition of metal. Time starts now. I think this is a basic and everyone should get it right.
Anatomy of the angle, 3 seconds to go. And your time is up.
This is the Schwalbe's line. And again, good, 74% have got it right. Rest have to go back to gonioscopy and not miss that line. The new drug on the block, ROCK inhibitors. How does it act? How does it decrease the IOP? A, decrease in the EVP. B, relaxation of trabecular muscles. Norepinephrine transport inhibition, or all of the above. Time starts now.
Very nicely formulated questions, easy to answer also. You have to keep your thinking cap on and answer. 6 seconds to go. And your time is up.
I hope everyone has got it right. It's all of the above. And again, a good 84% have given it right. Again, a straightforward question. What is this condition? Traumatic iridotomy, iridocorneal epithelial syndrome, iridotomy, or iris defect of pigment dispersion syndrome. Time starts now.
Six seconds to go.
Time's up. This is an iridocorneal epithelial syndrome. So it is important not to miss it as traumatic dialysis or trauma to the iris. This is a congenital condition and needs treatment in long term.
95% have given it right. Good.
Again, an interesting one. What is the procedure done in this patient? Is it a Zen gel implant? Is it an intracameral drug implant? Is it an eye stent or a hydrous micro stent? Time starts now. This is going to be the future of glaucoma treatment.
And your time is up.
I hope everyone has got it right. It's an intracameral drug implant. So this is what we'll be doing in future. Just put an implant there and the patient doesn't have to put drops for months together. I think again a good number of people have got it right. This is a type of glaucoma which can occur in all these conditions except one of them. What is that condition? Diabetes mellitus, hypertension, CRVO, or CRAO. You can look at the inset to get the clue.
Five seconds to go. Easier answer on glaucoma. And your time is up.
So this is CRAO. Now why CRAO? Because in CRAO there is total washout of the vasculature. So there is no stimulus to form new vessels. And here at least most of them have missed it. So I think we should get it corrected. Next question. In this patient, rise in the intraocular pressure can be due to blockage of the trabecular meshwork due to all except one, erythrocytes, fibrin and platelets, ghost cells, and all the above. When you encounter such patients, it's important to take quick steps to relieve them because it can lead to a very painful condition.
3 seconds to go.
Okay, time's up. In hyphema, ghost cells are not formed immediately because there is high oxygen pressure in the AC and due to rapid circulation. So ghost cells form later, and hence in such acute conditions you don't get them. Okay, so I think you are all quite stimulated with these questions, and let's rack up our brains and go ahead with the further questions. Internal ophthalmoplegia, is it seen in migraine, ethambutol toxicity, diabetes, or all the above? Time starts now. Okay, 9 seconds. 7, 6, 5, and time's up. It is seen in migraine. Rest of the conditions you won't have internal ophthalmoplegia. I think last question majority didn't get it right, so let's hope that this questions all of them get it right. Weber's syndrome, it involves 7th nerve palsy, 5th nerve palsy, 4th nerve palsy, or the 3rd nerve palsy. Time starts now.
Five seconds to go.
Good.
And your time is up.
So it's a 3rd nerve palsy because Weber syndrome or midband stroke syndrome is characterized by the presence of ipsilateral lower motor neuron type 3rd nerve palsy and contralateral hemiparesis or hemiplegia. As you can see in this diagram. Again, 91% have got it right. That's good.
Yes. Very nicely depicted picture, huh? Nitin? You can have
Right.
a change of guard after 20 questions.
Right.
Okay.
Now, this is an interesting thing which is seen in New Zealand. A population of glowworms called Arachnocampa luminosa illustrates the Waitomo caves on the North Island of New Zealand. These glowworms, which are unique to New Zealand, are bioluminescent. Thousands of them live along the cave ceiling, creating the illusion of an overhead sky full of stars. This is an interesting tidbit we got, so I think we would share it with you. Jignesh Mehta is having a little sore throat, so I'll go ahead with the next
Okay,
question.
go ahead. No issues.
And now it's retina, so again I will. Okay, now in this autosomal recessive transmission of the disease, which is the gene responsible for this autosomal recessive transmission? ABCD4 gene, ABCA4 gene, ELVOL4 gene, or ELVOL4 gene. So you have to identify the condition and the gene.
ABCC is written, so ABCD chahiye last. Anyway. Yeah, it has been corrected here. 5 seconds to go. Time is
Okay.
up.
Hope you have got it right. Yeah, most of them have got it right, almost 74%. That's a great thing. It's a Stargardt's disease, and this is an autofluorescent image. The dark area indicates that the RP is almost dead there, and in the white areas there is deposition of lipofuscin, and the gene responsible is the ABCA4 gene. Each parent carries a copy of the mutated gene. An easy one here now. This retinal degeneration goes by the name of which animal? Rat, cat, snail, crocodile. You should remember your childhood days. Rat, cat, snail, crocodile.
5 seconds to go. Interesting picture.
Okay, your time's up now. And the answer is obvious. It's a snail tract degeneration, which is a benign degeneration which usually does not require any treatment. All those who had played outside in childhood would see these snail tracks. Again, a very good percentage have got it right. So everyone has played in the childhood. This is a white dot syndrome. Identify it, whether it is multiple evanescent white dot syndrome or acute multiple pigment placoid epitheliopathy, birdshot chorioretinopathy, or serpiginous chorioretinopathy. Time starts now. White dot syndromes are always confusing.
Nice figure. 5 seconds to go. And the time is up.
It's the birdshot chorioretinopathy. Americans have that habit of giving some weird names. Now, why birdshot? It is the type of bullet which is used to shoot the birds. So, birdshot chorioretinopathy, chronic bilateral posterior uveitis, and it is a difficult condition to treat. Next question. Identify this condition where autofluorescent imaging clinches the diagnosis. Is it a Best disease, Coats disease, bestrophinopathy, or cone rod dystrophy? If you look at the autofluorescence image, you can see a necklace-like deposition of lipofuscin, which is almost missed on the color photo. Okay, the time is over. Let's see. It's called bestrophinopathy. It's a degenerative retinal disease caused by the Best genes. 33% had got it right. Well, it's a fairly new condition in literature, and I think most of us may not see it in their day-to-day practice, but still I think a good number have got it right. Identify this retinal condition. Is it a subretinal fibrosis? Is it a subretinal worm, a choroidal tear, or a choroidal neovascular membrane? Time starts now.
Very interesting picture can be seen very often. 5 seconds to go. Beautiful diagrams, black and white, and the colored photographs gives you a clue when the time is up.
So this is a choroidal tear. Usually it follows a blunt trauma. If the fovea is spared, as in this condition, your vision can be almost 6 and 6, but still you have to watch for development of choroidal neovascular membrane in future, which can then reduce the vision significantly.
Everybody is doing very fine now. 15 more questions to go. So buck up, everybody. Yeah, next.
Identify this condition. Is it a choroidal melanoma, a choroidal hemangioma, choroidal osteoma, or a choroidal tuberculoma? This is a color as well as a FFA image of the same patient. 10 seconds to go. Okay, the time's up. And the answer is choroidal osteoma. About 41% have got it right. Choroidal osteoma is a benign tumor. So it's important to know about it because it's a benign tumor and it is characterized by mature bone replacing the choroid. So this usually does not require treatment. Rarely it causes neovascular membrane involving the fovea, but most of the time it will remain benign. Now another slightly uncommon condition, is it choroidal sclerosis, choroideremia, ocular albinism, or chloroquine toxicity? The upper one is in wide field image and other is a montage color image. You can imagine the field of this patient. He'll have just a very small central field. Okay, the time's up and most of them again have given it right. Almost 70% have given it right. It's a choroideremia, which is an X-linked choroidal dystrophy, which leads to progressive degeneration of the RP, photoreceptors, and choriocapillaries, virtually leaving the patient legally blind. Okay, another question related to autofluorescent imaging, which is gaining more and more popularity with retinal surgeons. So, which is this characteristic image of angioid streak, chronic CSR, choroidal nevus, or ethambutol toxicity? It's a typical RP gutter, as they call it. Ten seconds to go. Well, time's up. So this is a situation seen in sick RP syndrome, which leads to RP alterations, and it's a feature of chronic central serous retinopathy. I think again most of them got it right. Almost 70% have got it right. Good going. Now this is a red-free image of a retinal condition, and again it is named after which animal? Tiger, elephant, bear, or leopard? Time starts now. Wildlife experts would be good at it. 6 seconds to go. Okay, the right answer is a bear track. Again, a good number. Almost 60% have got it right. It's a congenital RP hypertrophy. Again, benign in nature. It looks sometimes it can be mistaken for an inflammatory disease or a white dot syndrome, but it's just a non-specific congenital hypertrophy. Again, a simple question. Commonest associated refractive status with this retinal condition is hyperopia, myopia, astigmatism, and presbyopia. We are just asking for the refractive status. Their causes of these conditions are a lot of them. Okay, time's up, and the answer is hyperopia. These are choroidal folds which can be at times benign, or at times they can indicate an retroorbital tumor or other problems. And again, 75% have got it right.
10 more questions to go. Come on.
Commonest systemic association of this condition. So you have to identify the condition and the systemic association. Is it pseudoxanthoma elasticum, Ehlers-Danlos syndrome, Paget's disease, or sickle cell disease?
Fifteen seconds to go.
I think there's a mnemonic to remember the causes of this disease.
And your time is up.
Time is up. So these are angioid streaks, and the commonest systemic association with this condition is pseudoxanthoma elasticum. Again, angioid streaks most of the time don't cause any significant visual loss, but if it causes a choroidal neovascular membrane, patient can lose significant vision. Now, patients with AIDS will have all of this. That is Candida endophthalmitis, CMV retinitis, central serous retinopathy, toxoplasma chororetinitis. But one of them is not right. Which is the one? Time starts now. With the introduction of proper therapy for AIDS, we are not seeing these conditions so commonly now. But 15 years back, we had thought of them. The time's up, and the correct answer is central serous retinopathy. It is not a part of AIDS syndrome. It's just a non-specific swelling at the center of the retina. Bilateral retrobulbar neuritis occurs in neuromyelitis optica, multiple sclerosis, both the above conditions, or none of the above conditions. Time starts now. I think most of the people are getting the answers right, so that's a good thing. 7 seconds to go. 5, 4, 3, 2, and 1. So the right answer is both the above. Both neuromyelitic optica as well as multiple sclerosis can cause bilateral retrobulbar neuritis. And about 54% have got it right. Good going. This is a B scan image, and this is suggestive of.
Sorry. Don't
Optic.
answer it on the chat. Somebody is answering here on the chat. You have to do it only on Slido. Okay, go ahead. Sorry.
Okay, the B scan suggestive of optic nerve at drusen, anterior ischemic optic neuropathy, optic neuritis, and papilledema. I think everyone should get it right. B scan is useful in such conditions because it's easily available in our clinics, and it's not any hazardous side effects with this. Okay, time's up, and I think everyone's got it right. The optic nerve at drusen, a typical hyaline-like calcific material in the substance of the optic nerve, usually asymptomatic. If a lot of them occur there, sometimes you can call field defects. I think again 93% have got it right. Very good. This patient with post-trauma visual loss has intraocular foreign body, dislocated crystalline lens, retinal cyst, or pre-retinal hemorrhage. Time starts now. Again, in trauma cases, ultrasound is a good means of detecting and getting a quick diagnosis, especially when the media are hazy due to cataract or vitreous hemorrhage. Time is getting up now. Okay. So the correct answer is a dislocated crystalline lens. Again, 74% have got it right. Good. This is an A plus B scan image of an intraocular lesion. What's it? It's choroidal hemangioma, choroidal melanoma, massive subretinal hemorrhage, or a choroidal detachment. Time starts now. You have to look at both A and B scans to get the right answer. Okay, time's up, and hope everyone has got it right. Choroidal melanoma. It's a mushroom-shaped tumor with a low internal refractivity seen in the A scan. Very characteristic of a melanoma. And I think about 80% have got it right. Good.
4 more questions to go before the final countdown. Please.
This is a cinnamon roll-like structure sitting on the retina on this OCT picture. Is it a vitreous tag? Is it an epiretinal membrane? Is it an ILM flap or a cotton fiber? Time starts now. We had named this as a cinemal roll, and in the VRSI picture competition, we had got a prize in this image. Time is over. So it's an ILM flap. As you all know that when you do macular hole surgery to bridge the gap between the two lips of the hole, we peel the ILM and place it across the hole. But sometimes this is a post-operative picture, 2 weeks post-op. When we did the OCT, the ILM was not covering the hole, but it was sitting like a cinemal roll on the lip of the retina. We re-rolled it and closed the hole. Now another OCT picture. What is this suggestive of? Intraretinal hemorrhage, subretinal hemorrhage, sub-ILM hemorrhage, of sub-RP hemorrhage. Again, OCT is a good means of detecting such changes because we can see into the retinal layers, which was not possible earlier. Time starts now. Okay, time's over. So I think everyone must have got it right. Yes, sub-ILM hemorrhage, almost 51% have got it right. OCT is good means to detect this because if it is in sub-ILM hemorrhage, you immediately don't operate these patients, allow the hemorrhage to clear off on its own. If it is a subretinal or it is a pre-retinal, then with the management options are different. This is an OCT picture of a 35-year-old female with profound impairment of vision, and it suggests cystard macular edema, central serous retinopathy, Harada's disease, or an intraretinal cyst. Please look at all the layers of this OCT. Time starts now. And now it's over, and the answer is Harada's disease, which is a chronic posterior uveitis leading to significant loss of vision. This is a classic picture of extensive subretinal and intraretinal fluid. Along with, you can see the vitreous cavity, which also has exudates. So all these features suggestive of very chronic inflammation. Again, about 43% have got it right. And now the last question. This is an OCT picture of a 52-year-old male. This is a typical COVID times disease, immunocompromised due to COVID. So what does this suggest? And candida retinitis, toxoplasma chorioretinitis, acute multiple placoid pigment epitheliopathy, or a CMV retinitis. Time starts now. This image is part of a case which we had presented in IGO in the early phases of COVID disease. This patient responded well to treatment, but subsequently succumbed to the COVID disease. Okay, the answer is Candida retinitis, and again a good percent, 64% have got it right. This is an acute retinal inflammation caused by Candida and occurs due to reduced immunity. It responds to systemic as well as an intravitreal therapy. This brings us to the close of this quiz here. Thank you for participating and stimulating your brain on all these questions. Hope you have enjoyed it and have increased your knowledge.
Very nicely conducted quiz, Nitin and Medha. In fact, they were very interesting questions, good pictures to depict, to give good clues also. And I think majority have answered it so nicely. So it has been a very interesting quiz. Now we'll be waiting for the winners. I mean, the first 4 winners will get the prizes. In that, they have to become an MOS member in case they are not. So that is the rule. So here we have finished the correct answers. Here we have 4 people here we have taken the fastest finger first also, who has answered it quickly, and the maximum number of correct answers, both including we have Nasik Hassan. Can we upgrade them to this in case they are not Sai?
I'm doing it.
Kaushik Tripathi is there. He has already won the quiz earlier also. So he won't be eligible, but congratulations anyway. Mohammad Ibrahim Asif, he has got 33 out of 40 with 4.404 as the time. And Aniruddha Kapoor, 32 out of 40, 4.06 seconds to answer. And Manik, 32 out of 40, 4.58. Congratulations, all of you. We have to exclude Kaushik. So 4 of them, we can take them in. We like to have a quick chat with them. Can we upgrade them? Sai, are they there on the platform?
I have upgraded all the 4 of them.
Yeah. Can you say hi? I think let's have a gallery view.
Hi, I'm Dr. Nasik Hassan.
Yeah. Nasik Hassan,
Yes, sir.
congratulations. You have stood first.
Thank you,
And
sir.
you will definitely be eligible for prize. But are you an MOS member? We would like you to become an MOS member to claim the prize. Where are you from? Can you introduce shortly?
I'm Dr. Nasik from Tirunelveli. I'm a consultant at Agarwal Eye Hospital at Tirunelveli.
Wow.
Tamil Nadu, sir.
Congratulations, Nasik.
Thank you, sir.
Congratulations.
We are also part of the Aqueous group.
So I just got your message, so that's how I joined the quiz.
Very good, very good.
Good that you
Great.
participated and won the event.
Thank you.
Become an MOS member, boss. You'll
Sure, sir.
be able to give the. We'll be sending the link. Dr. Ajay Joshi is the honorary secretary.
Sure,
So
sir.
please share your mobile number. He'll share the link on that.
Yes,
And then
sir.
you can become. It's an online, very quick process. Within 2 minutes, you can become an MOS member. Once we have it, we'll be sending the prizes. The microvision people are there with us, so they will be sending the prizes on mail. There'll be, I think, most will be Amazon coupons, so you can utilize it your way.
Sure, sir.
Then we have Dr. Mohammad Asif.
Hello,
Yeah,
sir.
Mohammad.
I'm
33
Mohammad.
out of 40. Very good. Just introduce yourself properly. Let us know where are you from.
Sir, I'm right now staying in Delhi. I'm working in I7 hospital.
Wow.
I'm working as a cornea consultant.
Fantastic. So nice. See, we have got, it is an MOS quiz, but all over India, we have got good participants and they're winning the prizes too. So I hope you are also an MOS member. If not, please become one. That is what I would say to claim the prize. Congratulations.
Thank you.
You'll have to share your cell number with Dr. Ajay Joshi, or on the chat box, he'll make a note.
Okay.
Don't forget to do that. Yes, Aniruddha, she is the 3rd prize winner.
Good evening, everyone. I am Aniruddha Kapoor. I am from Delhi, and I'll be completing my MD ophthalmology from RP Center AIMS at this month, like in June.
Wow. We have a person from AIMS also participating. Congratulations.
And best of luck for your exams.
So it's already
And best of luck for your exam.
Already done. So we are waiting for the sweets now.
yes.
So, Aniruddha, share your number so we'll make you an MOS member so you can claim the prize. Thank you very much for joining. Manik, is he there? Mr. Dr. Manik? Sai is not there around, I think. Kaushik, Dr. Kaushik Tripathi, he is a winner, perpetual winner for so many, this thing, either 1st or 2nd. He is yet to receive the prizes, so we'll be sending it in due course because he had not become an MOS member, so he's an MOS member now. So everybody, a big thank you. Please share your mobile numbers so we can make you. Yeah, Kaushik is there. Yeah, Kaushik. A very good evening. Put your video on. Yeah, you are muted. Unmute yourself, please. Kaushik. Dr. Manik Sardana is also there, so we'll have a chat with him too. Dr. Manik, can you, yeah, where are you from? Just a small intro, please.
Good evening, sir. I am Dr. Manik. I am currently working as senior resident in PGI.
In BJ Medical,
Chandigarh.
Pune, Chennai.
PGI Chandigarh.
PGI Chandigarh.
BGI Chandigarh. Oh, that's great. So,
So how do they find our questions? Are they too easy or too tough?
Sir, they were of good quality, sir. Some
Very
difficult,
nice.
some easy.
Very good. Very good.
That is how if you make all the difficult, people won't start, they won't attend only. Arey, to बहुत difficult hai. So a little easier, mix and match has given you good this thing and you have won the prize. So
Yes, sir.
become an MOS member in case you are not, so you can claim the prize. Share your
Definitely,
mobile
sir.
number with Dr. Rajesh Joshi on this chat box. We'll do the needful as early as possible. Kaushik?
Yes, sir.
Yes.
I think some
तुम्हारा
problem
चेहरा
is there
दिखाओ
with
यार,
the,
सब लोगों
ये.
को परपेचुअल विनर है यार, जब भी आती हो कौशिक लेके जाता है, वो और प्रशोभ मोहन, 2 जन तो हमको बाहर हो गए नाम.
Sir, one more thing is that most of the people who have won are from RP Center AIMS.
अच्छा, yes.
हाँ.
RP Center is
Dr.
winning.
Nasik,
We
Dr.
have
Anirudh, Dr. Asif, and Dr. Kaushik.
we have, I think, Nasik Hassan is from Tirunelveli. He is also passed out from AIMS.
Yes, sir. I passed out from AIMS last year.
Wow.
My
So
senior residential-
kudos to AIMS people. Huh? Very well, I mean, academically very strong, winning away the prizes. I am so happy that the best is getting the prizes, whether they are MOS members or not. You become an MOS member, you claim the prize also. But congratulations anyway, all of you. Please don't forget to share your mobile number so we can send you the link. Thank you very much, each and every, and of course, Sai Numerotech for all the technical support, and our quiz masters, Dr. Nitin Prabhudesai and Meda, and Rajesh Joshi is also a backbone to the MOS our quiz also, and overall also is always a support to me. So thanks a lot. Next
Thank
time,
you,
I think we'll include a slide of the rules in between, so people will be aware of what exactly we have planned for you. Thanks a lot, each and
Thank you.
everybody.
Bye bye, everyone.
Bye bye,
you.
bye bye.
Thank you,
Take care.
sir. Thank you.
Everybody can log off. Me, Dr. Rajesh Joshi, and Sai should be there, please. Just like to discuss out. Thanks, everybody else.